Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and here for today's conversation is J. Patrick Lavo with Willis Knight & Bossier ENT and Allergy. Good afternoon, and thanks for joining us, Doctor.
I'm glad to be here. Thanks for having me.
Yes, and so this is a busy season
Absolutely.
for you,
Oh my gosh.
all the pollen, and so you see a lot of, I'm sure, people with allergies and
Absolutely.
fixing that and all
a big
that
part
good
of our
stuff.
practice is allergy and sinus and all the itchy, sneezy, drainy, awful that happens this time of year. Actually, year round in this
Right.
part of the country. It never stops growing here.
Yes. Okay. And so this is your first Healthline, and so
It is.
kind of introduce us to what you do at Willis Knight.
Okay. Well, hey, I'm Patrick Lavo. I'm one of the ear, nose, and throat physicians. There's about 4 or 5 of us at Willis Knight at this point, and we are in charge of your health from the neck up. We are the ones that you get referred to if you have thyroid problems, if you're not seeing an endocrinologist, although we work with the endocrinologist, so they'll refer to us and we refer to them. We're the people you see if you have sinus issues or you have allergies. We're the people you see if you have ear infections or strep throat. We also do skin cancer from your neck up. We also do head and neck cancer. We do a bunch of different stuff at Willis Knight, so
Right.
we're sort of responsible for a grouping of different organ systems and areas, but all regionally located, anatomically located.
Right. Okay. So it's like it's a seemingly small area, but
Correct.
lots of different things that could go wrong.
It's horrendous how many things can go wrong in your head and neck. It's just, that's where all of your important structures are. That's where all the major,
Right.
all of your cranial nerves are working in that area. All the nerves in general pass through that region to get to other portions of your body. So it's just an area that has a lot of
Traffic
a lot of
and
potential difficulty. Yes.
Yeah. Okay. And so why ENT? Why did you choose ENT for your practice?
So ENT is an interesting field because it's pretty broad. I knew I wanted to do something surgical because you get to do something with your hands, you get to keep it diverse. And then honestly, when I was going through med school, I really liked ENTs. They're all kind of quirky, odd people, but they're all pleasant and friendly and family oriented. And I was like, this is a fun field. This is a cool area. And then as I got to explore, okay, I can spend time with these people. And then as I got into the field as a result, I ended up really liking it and thinking, okay, this is an interesting area. This is kind of complicated and unique. So it's been fun.
I love that. Well, cool. And so we did talk about this on midday, but maybe mention it again. What are the most common things that you see as an ENT doctor?
Absolutely. So there's probably, you could probably think about something across the board. So if you think about ENT, right? So ear, nose, and throat. So if we talk about ears, the most common things we see are going to be hearing loss and tinnitus. So we see a lot of people who just came back from a concert, who just came back from the air show, and their ears are ringing. Or, they're in their 70s and they've worked as a welder their whole life and they're having some hearing loss. So we see a lot of that. We also see a lot of kids with ear infections. We see a lot of kids will develop ear infections somewhere between that 8-month age and probably about 3 to 4. And so if you get a lot of ear infections, you end up at an ENT. We see a fair bit of sinonasal allergies, chronic sinusitis, difficulty breathing through your nose. We see things like that. We see skin cancer in the head and neck. And then if we're talking about throat, we see a lot of difficulty swallowing, dysphagia, and then thyroid issues.
Okay, yes, and we did mention this off air, but what is the reason why I feel like kids have ear infections all the time?
Absolutely.
Or, it's just super common. But is that something that a kid can grow out of over time?
Absolutely.
Yeah.
So what happens is the way your body is supposed to function, the way it's supposed to work, is you're supposed to get air pressure equalizing behind your eardrum. And the way that functions is it goes through the back of your nose. So if you plug your nose and blow and you pop your eardrums, what you're doing is you're opening that eustachian tube in the back of your nose with air pressure, and that air moves up behind your eardrums, and that's lovely. When you yawn on an airplane and you clear all that pressure, what you're doing is you're allowing that air pressure to equalize. In kids, it doesn't work very well. So they're very compact back there. They have big adenoids, which is the inflammatory tissue that lives in the back of your nose. They get a ton of sinonasal infections because they're naive. They are immune naive to all of these different viral infections, so they'll get a cold all the time. And the combination of all those things means that their poor little eustachian tubes just don't work very well. So they end up getting negative pressure behind their eardrums, which is, again, that feeling you feel on an airplane. That's negative pressure developing behind your eardrum, and they'll get that, but they can't clear it. So over time, their eardrums will physically suck fluid up behind their eardrums, and then that fluid sits there long enough and it gets infected.
Right.
So kids will get that over and over and over again. So what we do is we put a little tiny hole in the eardrum, we slide a plastic tube through it, that's really all it is, and that allows allows air to equalize pressure, but not through the back of your nose like it's meant to do anatomically, but through the ear tube. And by doing that, all that fluid can drain out. They stop getting negative pressure in there to begin with, and they stop getting ear infections.
So you're kind of rerouting the plumbing.
That's absolutely what we're doing. Absolutely. We are putting in a new pressure release valve, and kids will tend to outgrow this. Almost universally, kids will outgrow ear infections by the age of maybe 4 or 5. Again, that's when they start to do a better job of blowing their noses. They start to do a better job of being able to clear their own ears. Their anatomy has spread out a little bit, so those poor little eustachian tubes aren't as crushed as they were, and also they stop getting quite so many viral infections at school.
So when, I guess, should a parent decide, should we wait it out until they grow out of it, or, when should they decide to have that surgery?
No, and that's actually kind of a tough decision to make. So usually the rule of thumb is if you've had 3 or 4 ear infections in the last 6 months, that's probably a decent indication. You need to at least go talk to an ENT or talk to your pediatrician. Pediatricians are awesome at this stuff. So go talk to your pediatrician, go see an ENT, because if you're having 3 or 4 in 6 months, it is probably getting to the point where it might require surgical intervention. Ear infections are rough because it's really hard to build up an appropriate concentration of antibiotics in your middle ear. So when you take antibiotics, you're taking it and you wanted to get enough antibiotics to wherever the infection is. But that middle ear space, that area behind your eardrum, is really hard to get enough antibiotics to. So kids have to take like twice the strength when they're doing ear infection antibiotics. So they end up being on crazy high doses of antibiotics. It makes it very hard to hear. It's kind of like you're living with earplugs in. And this is typically happening at a stage of life where they're learning to talk. So if you can't hear, it's really hard to learn how to talk. So a lot of kids will show up in our office because they have speech delay, or they aren't saying things, they're trying to talk, but it's unintelligible. And the answer a lot of the times is, well, they can't hear anything because their ears are full of fluid. Infected or not, their ears are full of fluid. So tubes typically will help correct that.
Gotcha. Okay, and so let's say they had the tubes placed, and then they grow out of the ear infections, and they're, an adult. Did they is that okay for those tubes to still be in place forever? They
fall out on their own.
Oh, okay.
So tubes, there's no such thing, it's not like a miracle, but it's almost, because it's fraught with very few complications. There are some, don't get me wrong, there's always complications associated with medical procedures, but very few. And then they tend to fall out on their own. So your eardrums, the external portion of your eardrum, the outside of your eardrum is skin, just like anywhere else in your body. And just like anywhere else in your body, that skin sheds and it sloughs over time. So what'll happen is that outer layer of your eardrum will slough off, and eventually that ear tube gets caught in that slough and it falls out. And then the hole that we put in your eardrum heals. 99% of the time the hole heals, and as long as you've outgrown ear infections, you don't have to do anything about it. So it really is just a temporary measure until you outgrow the problem, but it tends to be pretty painless other than that first surgery.
That's awesome.
No, it's great.
And on that note, if you're just joining us and you have a question for Dr. Lavo, he's an ear, nose, and throat doctor, you can give us a call at 318-219-4569, and we'll be happy to take those questions. But if you do call and you are watching maybe on your TV, we do ask that you turn your TV all the way down so that we can hear your question. And give us a call. That number is right there on your screen. So we've talked about the most common thing with ears, and affects a lot of kids. But another thing is tonsils.
Yes.
So tell me about when should someone consider getting their tonsils out?
So that is an excellent question. There's a pretty strict guideline on this, and it used to be back in the day, back when my grandfather wasn't in medicine, but when my grandfather's peers were practicing medicine, it feels like if the indication for tonsillectomy was, do you have tonsils? Well, you should probably have them removed. Nowadays, we're a little bit more cautious with that. We know there's some potential complications associated with tonsil surgery, so we don't just jump to tonsillectomy. But there's 2 people that we typically do it for. There are people who have just nonstop throat infections. So we all think about strep throat, and that's true. And there's some magic numbers associated with that, so it's not just you get strep a lot. Technically speaking, it's 7 times in 12 months, which is a lot of strep.
Yeah.
So parents are always miserable when they show up and they've only had 4 or 5, and I'm like, I really haven't hit the number yet. The other number is 5 times a year for 2 years or 3 times a year for 3. So it's a bunch all at once, or just consistently every few months for several years. Both are a good reason to get your tonsils out, because your tonsils tend to get inflamed and they can harbor that bacteria, and then those infections can actually be pretty impressive. And there's some weird post-streptococcal syndromes you can develop. You can actually have kidney problems after strep. You can get heart problems after strep. You can have some weird stuff that can crop up after 1 too many strep infections. So that's one indication. And the second is sleep apnea. So if you're familiar with sleep apnea, the concept that your throat shuts off when you're sleeping at night, so you don't get air anymore, your oxygen dips, you make these horrible noises. It's not just snoring, it's physically stopping breathing. And when that happens, it's bad for your brain, it's bad for your vessels, it's bad for a number of things. It's bad for your hormones, it's especially in kids, it's bad for all sorts of things. So in kids, most of the time, the largest portion of their throat is taken up by their tonsils. So if we go in and take out their tonsils and adenoids, it opens up their throat enough that all of that just goes away.
Yeah, that's a big one. Sleep apnea.
Absolutely.
And if you don't get enough sleep, because it's really impacting the quality of sleep.
Oh my gosh,
There's
yes.
so many issues.
Yeah, you'll sleep. You'll sleep. You'll lay there all night, but you'll feel terrible.
Okay, well, we have our first caller. Eileen, thanks for joining us.
Good morning. I have a question about the swallowing problem. I have a swallowing problem. What test do I need to ask my PC to have done for it?
Well, that's an excellent question. So swallowing problems come in a variety of flavors, and there's a lot of different complicated stuff going on with swallowing. So I would have to say it depends on what you're having. If you're having problems where it feels like food is getting caught in your throat, then it may be that you need to get a swallow study where we physically have you drink some dye and we take an x-ray of your neck as you're swallowing and we just watch. Is there something obstructing your swallow? Is the muscle moving in an uncoordinated fashion? If you feel like you're choking on things, like, oh my gosh, every time I have to cough and I feel like I'm choking on something, I'm getting pneumonia a lot, well, that could be a sign of something called aspiration, which is where food is going down the wrong pipe. You know, your airway sits in the front and your throat, which behind it carries food, sits right behind it. And if it's going down the wrong pipe, that can lead to a lot of other problems. And again, that may be an evaluation that either an ENT needs to do or a laryngologist, if we're getting even further down the specialist chain, needs to take a look at. But either way, it really depends on what's going on. Some people have problems swallowing. They cough food back up several hours later. And again, that can be a suggestion of something called a Zenker's diverticulum, which is a little pouch in the back of your throat. So it's definitely something worth bringing up with your PCP. Depending on what you're having done, though, it really dictates the kind of studies that need to be done. But absolutely, talk to your doctor about it and see what they say about which way you need to go. ENT, gastroenterology, laryngology. There's a bunch of people who help with swallow.
Okay. Okay, thank you very much, and y'all have a blessed day, and God bless y'all.
Thank you.
Thank you. Yeah, thanks for joining us. And if you're just joining us, again, that phone number is right there on your screen. And if you have a question specific to ear, nose, and throat, or anything, as you've said, above the shoulders.
Shoulders and up.
Okay, yeah, give us a call and ask your question. So on the subject of sleep apnea,
Sure.
there's a lot of new technology nowadays that is helping, especially, this is a really, really cool, I've actually interviewed a patient about this, the
Yeah.
Inspire hypoglossal nerve stimulator.
Correct.
Sounds like really fancy and complicated, but break it down for us.
It's super simple. Okay, so if you're familiar with a pacemaker, you're already familiar with the Inspire. So let's talk about a pacemaker. And I'm stepping a little bit outside my lane here because some cardiologist is going to call me and tell me how wrong I was. But a pacemaker is just a battery pack that gets implanted under your skin and it sits on top of the muscle. And that battery pack has two electrodes and they both run down to your heart. Oh, I'm going to run into my microphone, sorry. They both run down to your heart and they're hooked up to the muscles down there. And when that battery pack sends a little tiny electrical impulse to those muscles in your heart, those muscles contract. And so the impulses come at a routine rate and therefore your heart contracts at a regular rhythm. Pacemaker,
Yeah.
easy enough. This device is the exact same concept because all muscles, when they are stimulated by electricity, contract. That's all a muscle can do, it can contract. But this pacemaker, instead of living on the left side, lives on the right side, but it's the exact same location. It's underneath your skin, stitched on top of your muscle there, but the electrode, instead of running down to your heart, runs up to the nerve that controls your tongue, called your hypoglossal nerve, which is why it's called a hypoglossal stimulator. So what happens is when you turn it on at night, it's not on 24/7, but when you turn it on at night, the device can tell when you breathe in because it has a pressure sensor built into it. So when your chest expands and it feels that pressure sensor activate, it knows you're breathing in. It sends a little tiny electrical impulse to that hypoglossal nerve, which causes your tongue to contract. And when your tongue contracts, what does it do? It goes, Now, technically speaking, we don't turn up the device enough so that your tongue sticks out of your mouth, but it's the same function. So as your tongue contracts, the tongue is in this throat that is collapsing is the front wall. So if you could stimulate it just enough, it would open up your throat just enough to get air in. So every time you breathe in, that throat opens up, and then when you breathe out, it relaxes. And you breathe in, and it stimulates, and so your tongue sticks forward just a little bit, then you breathe out, and it relaxes. And it has a really high success rate. And it's a real, like I said, it's a very basic technology. This is not some crazy application of neurostimulation. It's really a super basic concept. It's electrical stimulation of a muscle, causing it to contract and get out of the way. What makes it cool is that it can turn on and off, and it's got this pressure sensor so it doesn't bother you. And again, probably the best thing about it is there are so few successful and viable options for sleep apnea sufferers that this is one of the first things that's come along in a long time that actually is effective. There have been a number of surgeries that have been attempted. There have been a number of procedures that have come and gone because they have a very low success rate. So, there's one back in, some people, and sometimes they work. There's a thing called a uvulopalato-pharyngoplasty, or a UP3, which basically you get your tonsils cut out and part of your soft palate removed. And it's the same concept. We're trying to create space in the back of your throat. But the success rate on that is very variable based on your anatomy, and it's incredibly painful, and it doesn't work for a lot of people. So there's, that's kind of fallen out of favor unless you're the perfect candidate for it. So this seems to have a nice balance of it's not particularly comorbid, it doesn't have a lot of problems associated with it, and it has a pretty high success rate. They quote an 80% success rate, and how you define success is a little nebulous there, but it's got about an 80% success rate and a 97% satisfaction rate, and people seem to really like it. And it's a cool option, again, in a world where there's not many options.
Yeah, right. And I think the misconception with sleep apnea is that it just affects people that are overweight or obese,
Correct.
But it could be just because of your anatomy, like just with what you're born with.
100%. So the most common physical feature associated with sleep apnea is neck circumference. And neck circumference is typically associated with overall body mass. So it's true, like if you're a sleep apnea sufferer and you are overweight, the number one thing that I would tell you to do is go try to lose weight. Because again, if you can lose weight overall, that tends to result in a skinnier neck, and skinnier necks tend to result in less sleep apnea, statistically speaking. This is not always the case.
Right.
I've done plenty of these Inspires at this point, and a lot of them are on people who are not overweight. And some of the worst sleep apnea sufferers I know are skinny guys with skinny necks, and it's just based on your anatomy. Like in my case, my jaw is not particularly far forward, and people who have more retrognathic jaws tend to have more trouble because your tongue sits a little further back, and the further your tongue is back, the more likely it is to collapse when you're asleep. So there's a number of different anatomic configurations that can lead to sleep apnea. Being overweight does make it worse, but it is not necessarily required.
Yeah, and you have to be a candidate for the surgery like this, right?
Absolutely.
Yeah.
So the number one cure for sleep apnea after weight loss, as anyone will tell you, is CPAP, continuous positive airway pressure. It works the exact same way. All it's doing is the back of your throat. If we think about that tube example, when you have a CPAP device, it is pushing air into the back of your throat to keep your throat open, so that pressure will just allow air to move in and out. It's almost the same thing as if you took one of those long, skinny balloons and you blew in it just enough to hold it out, but not enough to actually inflate it. That's all CPAP is doing.
Yeah.
And this device is doing the same thing, it's just doing it with electrical stimulation instead of air pressure. But at the end of the day, CPAP is the gold standard. So you can't even attempt an Inspire until you've attempted CPAP and failed it. Like it's a prerequisite for this device.
Gotcha. Okay, we have our second caller. Elizabeth, thanks for joining us, and what's your question?
Hi. I was wondering, in his profession, does he have anything to do with hair loss?
Yes, actually. So I do not personally deal with hair loss, but ENT specifically does deal with hair loss. A branch of ENT is facial plastics, and ENT facial plastics deals with hair loss. I may be able to answer a question if you have one, but I don't know. Let's try. Oh no, she has no more.
Oh, Elizabeth, did you?
It just started thinning. My hair just started thinning, and it's just still thinning.
I gotcha. Well, and there can be a couple reasons for that. So there's a few things that you should definitely start looking into. So number one, you need to talk to your endocrinologist, because endocrine problems can be a chief cause of hair loss. So if you're having thinning hair, you need to make sure that your thyroid is correct. You need to make sure that your other endocrine system is all in line. The other thing that it could be is it could just be hair loss. If you have a family history of this, if you have some sort of genetic predisposition to hair loss, it's totally not impossible. We think about male pattern baldness, but the truth is there is female pattern baldness. It's less common, but it's definitely a possibility. There are different medical options for that. There are different procedural options for that. And at the end of the day, there are different surgical options for that too. But I would say your first stop in the road if you're having hair loss and thinning is you need to talk to your primary care doctor, because you need to make sure that all of your hormones are in appropriate lines and that all of your other lab work and electrolytes look like they're doing well. Because if those are in line, that's when you can start talking about, okay, what are my medical and procedural options? But you want to make sure that this isn't a sign of some other underlying medical condition, because hair loss can suggest a number of different things.
All right. Well,
Okay. Thank you very much.
Well, thank you.
Yeah, thanks, Elizabeth. And if you're just joining us, we are talking about everything above the shoulders, ear, nose, and throat with Dr. Lavo. And William, thanks for joining us. What's your question?
Yes, I've had tinnitus for 20, 25 years. What new development has medical science come up with that? I know it's, I see things on, even a commercial on TV for a product that will relieve you of tinnitus. I mean, I'm sure these scams have been going around for a while. But
Yes. I like that. I like that these scams have been going around for a while, because I will say that they are by and large scams. So be careful. Tinnitus is relatively poorly understood. And I'll say that with a caveat. We get it, we know what causes it. There are medications that can cause tinnitus if you're on aspirin daily. So fun fact, daily aspirin can actually result in tinnitus. There's a few different blood pressure medications. Furosemide or Lasix is commonly thought to cause tinnitus. There's some random antidepressants that can cause tinnitus. There's a chemotherapy in your past can cause tinnitus. All of tinnitus is thought to be an irregular electrical activity happening in the temporal lobe of your brain. So your temporal lobe lives on either side of your brain, and that's the part of your brain that processes hearing. As there is damage in your inner ear, in your cochlea, where those little hair cells live that are responsible for deflecting when sound hits it, and when they deflect, your brain gets those signals and says, okay, that's what sound was. As there's damage to those, or there's damage to that nerve, your brain stops getting all of those signals that it was supposed to get. Or it starts getting irregular signals from those damaged, broken, bent hair cells. And as that happens, you get this weird feedback loop that can start to happen. So the feedback loop is this electrical current that will move through your temporal lobe, and as a result, your brain says, okay, I'm getting electrical stimulation in this area that's supposed to represent sound. That must be sound. Okay, so then you'll hear this buzzing sound, because your brain is like, yeah, that's what we're hearing. We're hearing a buzzing sound. That's no big deal. But the truth is, it's not a sound at all. It's just this irregular electrical activity. It can actually be caused by, there's a recent movement towards this thing called cervical tinnitus, where people will develop tinnitus after they have like neck injuries. Again, this thought is that there's this aberrant neural activity causing this hearing that you're having. But we know that the most common thing that results in tinnitus is hearing loss. So the most common reason that people have tinnitus, especially around here, is we've got these guys who come in from Barksdale and they're like, you know, I've worked on the flight line for 20 years. Most of the time I wear my hearing protection, but now I get this loud ringing. What do I do? And the answer is, well, first thing you got to do is you have to get a hearing test, because we need to determine, okay, do you have legitimate hearing loss that needs care? And then the second thing we do is we talk about hearing aids, because if your hearing loss is what's leading to your tinnitus, the best thing you can do for it is hearing aids. It's like glasses, but for your ears. And just like glasses, it is not a magical cure. When I take my glasses off, I don't see as well as I did when I was wearing them. And when you take your hearing aids off, that tinnitus comes roaring back. But it does have a significant impact on improving the symptoms of tinnitus while you're wearing them. Because again, you're turning up the sound, you're decreasing that feedback loop that's going on in your brain, and as a result, you're getting less of that buzzing. But as far as there is some research in the pipeline, and tinnitus is one of those big things. You know, everybody's out for it, because the guy who cures tinnitus is going to be a billionaire. So everybody's trying to find it. Okay, what is it? Is it this thing? Is it this thing? And so there's a lot of research being done on it, but there haven't been any big breakthroughs as far as tinnitus cures. You know, there's some thoughts of deep brain stimulators or brain stem stimulators, things like that, to try to change the way your neural stimulation is happening. But none of that is mainstream just yet.
well, thank you so much. It's never been explained to me like that. I appreciate it so much.
Well, we're glad. Thanks for calling in.
Yeah, thanks, William, and hopefully we can maybe you will be the one to find the cure one of these days.
That'd be great. That would be awesome.
Yeah, well, and I'm sure there's groundbreaking things going on, you know, in ENT all the time, but specifically with sinuses, I feel like this affects a lot of different people. So when would sinuses be something that you would treat medically or surgically?
So sinus problems are super normal. So technically speaking, from like a normal perspective, everybody should have about 2 sinus infections a year.
Okay.
Everybody who comes in, they're like, I get a sinus infection every fall. What's wrong with me? Do I need surgery? And the answer is no, you don't, because having 1 or 2 sinus infections a year is totally within the realm of normal. So you don't need anything crazy. The people who we're talking about who need sinus surgery are the people who have 4 or 7 sinus infections a year. They haven't been able to breathe through their nose since they were 12. They can't smell anything anymore. These are people who have such significant sinonasal inflammation that they really do need someone to go in there and clean it out. Your sinuses and nasal tract in general are lined in these little hair cells, and their whole job is to push mucus from the front of your nose to the back of your nose. There's actually a test that you can do in the office. I don't recommend doing it at home, but you basically take Splenda and you put it just on the inside of your nose, and then you count how many minutes it takes for you to taste it.
Oh, wow.
And that's because your body will slowly move all that junk to the back of your nose and drop it down the back of your throat. So eventually you'll be like, oh, there it is, there's that sweet flavor. So don't do that at home. But the purpose of all that is to clear your sinuses. So they have this natural mechanism of moving all that junk out. So everybody's swallowing like a pint of mucus every day.
Gross.
So everyone who says, oh, right? But everyone says like, oh, I've got postnasal drip. It's like, well, you and everybody. The issue is more like, are you having extra postnasal drip? Is yours particularly irritating? Why are you noticing it? Because we all have it all day, every day. Your nose is constantly dropping mucus down the back of your throat. That's its job. But the problem gets to be if those cilia, if those little hair cells that are kicking all that snot towards the back of your throat stop doing their job very effectively, then you can get bacteria that builds up in your sinuses, or you can get mucus that just won't come out, like these inspissated secretions, which is a fun medical word. You should use that in a conversation today. But these inspissated secretions that will live in a cheek sinus and they just won't come out, and there's just nothing you can do about it. And the problem over time gets to be your sinuses are like a room with a door, but the door is only cracked. It's not really open very wide. So the inflammation, well, and I'll do this with my patients in the clinic, you shut the door and the inflammation closes the door. Now the problem is now we can't get out. So we've got all this inflammation and infection. We got nowhere to go because we shut the door. So sinus surgery, the whole purpose is we basically go in, and if you think about it from a construction standpoint, we take the door off the hinges and we blow out a little bit of the drywall next to it, because our goal is to create a much larger drainage pathway so that your body can start doing what it's supposed to do on its own. You know, sinus surgery does not cure allergies. It does not cure ciliary motility issues. It doesn't cure, what it cures is these obstructions that have been developed by chronic inflammation.
Yeah, okay, wow, great way to explain that too. And I'm sure a lot of people are experiencing issues with their sinuses right now.
Gosh, yes.
And there's going to be things out there on the internet, on WebMD, of like what you should do at home or home remedies. What are the things that you actually recommend to your patients to treat that?
Okay, so there's a couple things, and there's a lot of over-the-counter stuff that you can actually do that's really effective.
Okay.
So number one, Flonase. So Flonase, fluticasone, Nasonex, Rhinocort. There's a bunch of different medications that are all nasal steroids that you can spray into your nose. So if you've got diabetes or if you've got ocular conditions, eye problems, you ought to talk to your doctor before you do it. But these are all over the counter because they were deemed safe enough for people to just buy and use, like Tylenol, and they work great. Now they don't work great as a response. This isn't like Tylenol where when you get a headache, pop a Tylenol, you feel better. This is more like, I know I have allergies every March through May. Well, then probably late February, you should start using one of those nasal sprays every single day, and you should stop using it when June rolls around because it works much better in a preventative fashion.
Gotcha.
Those work great. Any of the over-the-counter antihistamines, so Zyrtec, Allegra, they're all basically brothers. They all do the same thing. They're just slight different chemical compositions. But realistically, if you don't like Allegra, try Zyrtec. It's a little different. If you don't like that, try Zysol. They're all just like the same thing, but a little different. And then the last one, and the one that does seem a little bit hokey, but actually works, is a nasal irrigation. It is not magic. It is, some people will swear it's just magic, but the truth is, it's rinsing out some of that thick mucus. And as we were talking about earlier, your nose is designed to move all that stuff out of itself. It's supposed to clean itself out. But when it's really inflamed and really irritated, you'll get this really thick, tenacious snot, which is gross. But you've had it when you try to blow your nose and it just won't come out.
Yes.
And it's like, oh, this is gross. Well, your nose also has a hard time moving it out on its own when that's the case. And by using those nasal saline rinses, you rinse out some of the thick stuff, and you also thin out some of the thick stuff so that your nose can do its own job better. So those actually do work. Now, if you do it, you got to use distilled water because tap water is gross. So use a rinse with distilled water and the little packets of salt that come with the thing. Clean your bottle regularly per the package instructions, but they actually work great. Like everyone that I do sinus surgery on goes home with a squeeze bottle to rinse out their nose because it actually makes a difference. Nice,
great tips. Well, we have just about a minute left, so where can people find you?
Okay, well, I'm in Bossier. Hey, I work over at Willis Knighton in Bossier. There's a bunch of ENTs in town though, so they're all I like all the ENTs in town. Truthfully, that sounds terrible, but they're all great guys.
No, that's great.
Willis Knighton has a bunch of great ENTs in their employ. So if you live over in Shreveport, check out Beal over here on Uri.
Yeah.
He's a great guy. But I particularly am at BossierENT.com if you want to check it out, or if you want to get an appointment. We're 212-7288. So 318-212-7288.
It's right there on your screen too.
I don't require referrals, so if you call me, we'll get you in.
Great. This has been so informative. Thanks, Dr. Lavo.
Well, thanks for having me.
Yes, it's great to meet you. And if you missed this or if you wanted to rewatch this will be on our website at ktbs.com/podcast, or you can also find it on Spotify at Healthline 3.